Welcome everyone to this month's Teach Educational Rounds. Here with us today moderating our discussion is Dr. Peter Selby. We'll be discussing transitioning to a hybrid care model, which is a bit of a continuation on from our session in February on virtual care. So I'm just going to begin with our land acknowledgement as well as some housekeeping items, and then we can get going. So KMH is situated on lands that have been occupied by First Nations for millennia. Lands rich in civilizations with knowledge of medicine, architecture, technology, and extensive trade routes throughout the Americas. In 1860, the site of KMH appeared in the Colonial Records Office of the British Crown as a council grounds of the Mississaugas of the New Credit, as they were known at the time. Today, Toronto is covered by the Toronto Purchase Treaty No. 13 of 1805 with the Mississaugas of the Credit. Toronto is now home to a vast diversity of First Nations, Inuit, and Métis who enrich this city. KMH is committed to reconciliation. We will honor the land through programs and places that reflect and respect its heritage. We will embrace the healing traditions of the ancestors and weave them into our caring practices. We will create new relationships and partnerships with First Nations, Inuit, and Métis, and share the land and protect it for future generations. Now, I encourage everyone to introduce yourself in the chat and let us know which traditional territory you are joining us from today. If you're not sure, you can check out the website there. I can put the link in the chat. Give me 1 second. And while you're doing that, I'll also introduce myself for those that are joining for the first time. So my name is Natalie, and I'm actually currently located at KMH, so on the lands of the Mississaugas of the Credit. I'm a third generation Canadian. In 1958, my grandparents arrived on a boat from Italy. And now living in the west end of Toronto, I've truly grown to appreciate the community and the vibrancy that this land has to offer. And I acknowledge the privilege I have as a white settler to live here, and especially as someone with type 1 diabetes, to have easy access to insulin and all my other required medical supplies. So I myself am committed to reconciliation. I continue to listen and learn about the stories and cultures of various Indigenous communities and ensure that their voices are heard and reflected within my work and personal life. So thank you to everyone who has shared so far. Please do keep sharing. We do read all of your comments and appreciate them. In the meantime, I will continue on with some housekeeping items. So if you're interested in receiving a letter of completion for this Teach Educational Rounds, please make sure you have registered for the webinar and completed the pre-learning assessment. As well, make sure you signed into the webinar using your full first name and last name so we can track participation. And lastly, make sure to complete the evaluation and post-learning assessment that will be emailed to you by the end of the day, and you'll have a week to complete that. Along with that, you will also be receiving the link to this recording if you would like to share or rewatch. So here's a little bit more information on our moderator today. So Dr. Selby is a senior medical consultant and clinician scientist in the addictions division here at KMH. His research focuses on innovative methods to understand and treat addictive behaviors and their comorbidities. He uses technology to combine clinical medicine and public health methods to scale up and test health interventions. His cohort of more than 300,000 treated smokers in Ontario is an example of this. So welcome, Dr. Selby. And here are his disclosures. So I'll give everyone just a moment to read through those. We also have our two panelists today. So first up, we have Alexander Abramenko, who is an artist and a longtime client of the STOP program in the Nicotine Dependence Clinic, as well as Compass at KMH. So welcome, Alex. As well, we have Huma, who is one of our social workers at the Nicotine Dependence Clinic here at KMH. She works closely with the clinical team to provide individual and group support to clients who are interested in making changes to their nicotine use. And so no disclosures on their end. So please note that the content of Teach Educational Rounds is centered on evidence-based guidelines from the following sources. Nonetheless, these materials, as well as the verbal presentation and any discussion, represent only general principles, and they do not remove the need for clinical assessments or treatment plans by healthcare professionals. So please feel welcome to use the chat feature throughout the webinar to post any comments or questions. To do this, you can click on the speech bubble icon in the control panel at the bottom. This is very open-ended discussion based today, so please do feel free to post any comments throughout the webinar, and hopefully we can get to everyone's questions. So with that, I will hand it off to Peter to take it away. Thank you, everyone, and enjoy the webinar.
So thank you very much. And thank you for that, Nellie, and welcome. So I'm just going to, whoops, can't save the movement. All right. So welcome. So I think we're talking about smoking cessation transitioning to hybrid care model. I think all of us have had to adapt in some way to a sudden adaptation to once the pandemic hit us. Some of us were doing, you know, remote consultations and work, especially if you lived in northern parts of our country. There was a lot of healthcare that was delivered through in Ontario, OTN, and in fact, some of the earlier versions of telemedicine occurred, initiated by several First Nations actually. So this is nothing new in terms of transitioning, but the transitions are always happening, right? So we transitioned from in-person care a lot of the times in urban areas to completely virtual care, and then are now back into another model, which is trying to get back to hybrid, which is both in person and it's very interesting as we watch this as to what is the best practice and what is the best ways to do that, and hopefully in the times that we go by, I'm going to ask Alex and Huma to comment. And what I'd like to do is start off with you, Alex, first, and just get your thoughts about and whatever you're comfortable with. So first of all, thank you for being here, but also what you're comfortable with sharing about your experience from before and during, and maybe before March 2020, what it was like for you, what it was from 2020 on, and then where we are today, and your thoughts.
Right. Yeah, sure. Thank you everyone for being here, first of all. And it's really cool
and
that,
sorry, maybe we can stop sharing the slide. Maybe that way would help us just have a conversation. Thanks. Yeah, go ahead.
Right. Yeah, so thank you for listening, everyone. It's really cool to have so many diverse people listening to our experience. Anyway, so what was it like for me as a client to transition from in-person to online at the beginning of the pandemic? That's the question, correct?
Yeah.
Right. So the first thing that I would like to mention is that it was a very sudden change, obviously for all of us, but there was no warning. And to my memory, I remember being in a therapy session in person, and then it's almost like all of a sudden we were just not doing that anymore. Well, that's pretty much the way it was. But I actually found that I experienced very little hesitation. I mean, maybe internally, or in my thought process, and somehow as a bit of a shy person too, maybe I had some hesitations, but actually it was surprisingly organic, the transition. Perhaps part of that is because I'm of a generation that's more or less native to digital space. I don't know, so I can't speak from all ages, all age groups, but I was really surprised how organic it felt, even though the whole process was pretty spontaneous.
And can you speak a little bit about how it was for you to have, somebody with a camera looking at you in your own space, as opposed to, typically would come to a clinic and,
Right.
you could be in your own space, and we are coming into your space.
Yeah, that's the that's the thing. That would be most people's concern, and it was mine to some degree, but again, there was just something about about the format that doesn't feel as invasive as yeah, there's something about the experience of being in front of the camera in your own home that actually feels less invasive than being in front of, let's say, 15 or 20 people in real life. So I think if anything, it might be more comfortable for someone who's a stage shy or camera shy, or even socially shy.
Yeah.
Um,
And
yeah.
so how is it keeping the camera on and for you and not being able to see and look into the eyes of your therapist, not make eye contact really? How is that?
Well, actually, um, that is a good question, because I find that seeing my therapist or seeing my fellow, group mates, or if it's a group situation, I think it's very important to see them, and it's very difficult if I don't see them. Actually, I find it a bit difficult right now because I don't see everyone, obviously, because there are so many of you, I can't see you all at once.
Yeah.
But it helps to see a face looking back at you, because obviously it's you perceive someone. If you see someone, you perceive them as actually listening to you, and that's a bit difficult if you don't see them. And also, if you see yourself, you somehow feel more in control of your own space as well.
Thank you. So, Huma, I'd like you to jump in as well, and as a therapist, maybe introduce a little bit about your work you do, and so people know where you're coming from and how it was for you. Same questions that I asked Alex.
Yeah, absolutely. So I started in research at the clinic, and actually we were doing virtual kind of care in that way, working on technology-enabled collaborative care. So I had a little bit of experience with that before we had the pandemic come along and change everything for us. But I was working in the clinic back when we were, 100% in person, seeing everybody on site or on the phone. We didn't have video at that point. So I had experience with that. And then exactly like Alex said, it was pretty much overnight really that everything changed for us, where it was kind of like, all right, you're working from home and we're going to speak to clients over the phone. And the video piece kind of came in a little bit later. For the most part, we've been using video in the clinic for groups and a few assessments. But we're doing a lot of assessments over the phone, a lot of treatment calls over the phone. And now, as the title of this webinar kind of lets you know, we're switching to a hybrid model where we have people coming on site, we're still seeing people virtually, we're still doing groups virtually. So it's a bit of a mix and a bit of a change as we get used to kind of adjusting to what this looks like. And I think it's going slow because I think everybody's kind of trying to figure out what this really means for them. We're adding back commute times for people for their appointments. For us as well, we're adding back those commute times. So it's an adjustment, and I think we're trying to pick out the best of both worlds. The convenience of having things virtually, but also the comfort of being able to see someone in person that, exactly like we're talking about, you don't have that virtually. I can kind of look at your faces here, but you don't know whose face I'm looking at if we're in a room of more than one person. So yeah, it's an interesting switch for sure.
Yeah, thanks. Yeah, and again, as a provider for me, as we went, it was very interesting. We see people who smoke who are highly, highly disadvantaged, and I would say maybe 5% of my clients actually had video.
Mm-hmm. Mm-hmm.
So they either did not have internet, they did not have the ability, or if they did have, they were not necessarily technically literate to be able to join the software. And it was interesting. Obviously, at that time, there was no way for them to come in person because everything was shut down.
Yeah.
But during that time, there were still a few people who wanted to come in person despite that, because they didn't have this privacy, for example, to do, the assessment. They lived in a rooming house, or they lived in a group home, or they didn't have the privacy. And the other thing is that, or they were in a shelter. So, so coming in was a place to come into some place to be. And so as soon as we were allowed to bring people in for that it was quite important actually for some, and some people would say this is the only time I'm actually getting out to meet people. I know it's masked and I know I have to get tested, but so they would come
Yeah.
for that. So there's this one size fits all approach is not going to work, and right. And so as we are coming, I hate to say back because
Mhm.
in a way you're returning to you're returning to a space, and we always feel like it's going back, but you're never going back. Nobody ever goes back 2 years anyway, right? I mean, if you in 2020, we won't say, oh, we've got to go back to doing work how we did in 2018.
Yeah.
It's like it's a new world, so it's reattaching to work. So it's reattaching to the hybrid model. So if you had to think about your clients as you're thinking about this, who are the clients you think we should be offering remote, and who are the clients we should be offering in person? Just broad categories.
Sure. Yeah, I think remote works well for younger people, especially those in school, because we're the hours of our clinic also limit that a little bit. So if they finish school at 3 and it takes them an hour to get to our clinic,
Yeah.
they kind of run out of time. So in that regard, virtual works really well. And people who are further away, of course, especially for us as therapists, we don't have to provide them with a prescription, so they can speak to us from a distance, and that's okay. So people who are working, people who are further away, that works. In terms of in person, it definitely helps if they're more complex, if they come in person. Obviously, people who don't feel comfortable with technology because I spend so much time in those situations trying to guide people through the technology that it takes away from the actual care piece. We have less time to do that. Um, so I think in those situations, it kind of, you kind of have to decide what works best for people. And sometimes it's not what they want. They would prefer to be able to do everything over the phone, but it just doesn't work out that way. So broadly, those would be my categories.
Great, thank you. And from your perspective, Alex, as an individual, which parts of the care plan, if you were, if you're trying to quit tobacco use, that you would say, yeah, for this, I'm good to do it virtually, but these things I really want to come in person.
Right. It's a good question. I guess more routine things like the regular physician checkups. I don't know whether that's part of every smoking cessation program that's out there, but they were of mine, and that can be done over the phone, I think, pretty easily. But when it comes to, let's say, a client has individual therapy sessions as part of their treatment plan, just because so much of the communication that we do is nonverbal, I think obviously those parts where a more personalized approach is required, it helps to have the person in it helps to see the therapist in person at
Yeah.
least once anyway, at least once to establish a rapport with the entire um, continuum of communication.
Yeah. No, absolutely. Thank you. And one of the things I think we've at least I've noticed is for those who have been doing therapy, typically when people come in for counseling or behavior change appointments, if they come in person, they've had that time before to sort of prepare themselves for the appointment. They come, there's a waiting in the waiting room, there's a check-in, and then they come in, and then we start. And and then when they're done, they have to, they go out, they book their follow-up appointment, and then they have to commute back to whatever. That time often allows for reflection. So first of all, getting ready and then reflection.
Mhm.
Would you mind sharing some thoughts about when you do it remotely, that you're doing everything till the appointment starts, and then you jump off and you get back to everything else you're doing, and the distractions or the interactions that happen in your life, the
Yeah.
tasks available, work. How do you think that what I'm talking about makes a difference? Does it make a difference, or is it just am I just making it up, or how do you
No, I
see
think it does. I don't think you're making it out because I think it's true that whenever we're presented with new information, and if we have some time to absorb it immediately after its reception, I think it settles better. So That's a problem. I can imagine in my own particular case, I have my lifestyle is such that I can afford a little bit of time before and after.
Mhm.
But yeah, it's I think you're right. I think it gets you in the mood, so to speak, to
Mhm.
have a timeout before and a timeout after. Because when you're, especially if you're doing it remotely, chances are you're trying to squeeze this in between a lot of other things, and that time for self-reflection is gone. So that's, I can see that being a bit of a problem, or a huge point of difference between the two approaches. But perhaps that's why when we are asked to log in 15 minutes prior to the beginning of the session, that time can be used sometimes to do that, but it's a little more difficult than in real life.
Huma, would you like to also add to that, or your perspective as a team?
Yeah, sure. Yeah, I think that's definitely something that's different, and I think we didn't really anticipate that until we got into doing virtual care and realized that, people were taking our phone calls while they're at work or during their lunchtime or, in between running to other things. So it absolutely is kind of jumping right in, whereas before they would commute to our office, they would sit in our waiting room. Before they left, they'd be waiting for us to book a follow-up. So it does give that like before and after time. And as Alex mentioned, so for our groups, at least when we do virtual care, we do ask people to log in 15 minutes before. We check in with everybody individually before we start the group just to make sure everyone's doing all right. And so that kind of gives a little bit of time to people to kind of, get into the headspace of group. But we don't have anything after group, and that's hard to create too, because how do you say, okay, well, hang around for 15 minutes and we'll just kind of sit in silence? That's not something we can really do. Um, so that is a bit of a challenge, and I guess everyone kind of handles it differently. Some people say, I think about it as I kind of finish up and I'm cooking dinner that night or whatever it might be. But again, I think that's different individually, whether or not people do process the information that way or they're doing it, before they go to bed or whatever it might be. But
Yeah.
there's definitely a delay, I would say, compared to before.
Yeah, thanks for that. And I'm beginning to wonder whether, as part of these kinds of, when you're doing this virtually, whether we should have some sort of arrival practice,
Mm.
which is, as you start the group, obviously, because the difference previously was that people would talk to each other outside of the group, right? Everybody's arriving, they chat with each other. Here, it's one-on-one. The therapist talks to the person. The group doesn't talk to each other like they do in person. And
Right.
and that sometimes doesn't lead to the group cohesion that you want. But of course, it can occur during the group. But I'm wondering if an arrival practice, which is a way to get present, might help. And then at the end, in the closeout, is it possible to do a departure practice with another bit of reflection, and then people can reflect on the next steps for them. So yeah, 15 minutes of silence without anybody talking may not be the best way, but I
Mm.
wonder if we're doing some really quick, 3 breath arrival practices or 4 breath arrival practices and then departure practices that with the commitment might allow for some of that consolidation of the learning and the insights that might have developed during group, which is different in person. But again, as we move to hybrid, so getting more into the hybrid, I think there are lots of questions here. So maybe we should just go quickly to the questions because, um, there are some questions here about the virtual care offer extended hours. Yes, I think maybe you can talk about the pattern
Yeah.
of the groups that you offer.
Sure. Yeah. So, for the most part, our hours are kind of like between 8 a.m. to 5 p.m. We all kind of work within those hours for the most part, but we do recognize people have work and, they can't always make it during those hours. So we do offer a group on Monday evenings that starts at around 5 p.m., 4:45, 5 p.m., and that goes till 6:30. So that's kind of our after hours kind of group. And then, we're considering what people are interested in. That one is virtual, and we may keep it virtual because, again, if people are commuting after work, it doesn't make sense to have that group and then they can't make it. So that's that group.
Yeah, and then there's another question. So thank you for that question, Kathy. And platforms, you could use any platform. You have to use a platform that sort of has privacy things. So CAMH this one which we're using, WebEx Teams is what is approved, but you could use Microsoft Teams, you could use Zoom, whatever has been approved for within Ontario. If you're not in Ontario, that's been approved by your health authority or your hospital. That's what I would use. But yeah. And then currently we are in the webinar mode, but that you'd be doing it in the meeting mode. You wouldn't be doing it in the webinar mode because you want everybody to see each other, correct? Yeah. Okay. And Claire had this question: why choose one over the other, and why not combine in-person and on-phone computer? I mean, this is where the hybrid. I think. Can you talk a little bit about what are your thoughts about having some people on the phone and computer and some people in person? Does that work?
So, like at the same time, to do that, especially for a group, I think there's challenges to that because I think the risk there is then you kind of have a separation between the people on the computer and the people in person. And to manage the crosstalk might be a little bit hard. People on the computer might feel left out, or people in person might feel left out. So that one is something that we've considered, but I don't know if we've come up with a solution that kind of makes us happy at the moment. But who knows? That may be something that we end up doing because we recognize that people are getting something out of the virtual groups and people do want to come back for in-person groups. So it just kind of depends. We don't really have an answer for that one, unfortunately. Oh, I think you're muted, Peter.
Sorry, I muted myself because the fire truck was going by. Yeah, I think you have to look at your situation and what is the distance that people have to travel, what is the means in which they can get to you, and then what is balancing that piece is critical. In the group size, when you're going, how big are you generally doing in-person groups, and how big would your online groups be?
I think they're similar, to be honest, in terms of the amount of people who actually attend. Um, we our well-attended groups are like 7 clients in a given session. Average usually is about 4 we have showing up. On our list, we have anywhere from 10 to 12 that are kind of registered to come each week. So it fluctuates, and I think that's kind of how it was when we were in person as well. So it hasn't really changed, but we have been able to open up our groups. So we run more groups now than we did in person just because we're able to, which is nice.
Yeah, so there's some advantages of being able to offer more, and of course, people don't just hang around after to chit chat in the group like online. It's when you're done, you're done, kind of thing, is it?
Sometimes they do, yeah. So sometimes, but it's not usually with each other. Before when we did things in person, clients may kind of, chat amongst themselves as they were leaving. But now it's not so much amongst themselves. It's if they have something to mention to the facilitators, then they may stick around and have a little bit of a chat with us. But yeah, other than that, most people usually sign off when we say, okay, we'll see you next week.
Okay. And Claire's talking about, if people are doing some sessions online in person, but some are virtual, is that an appropriate way to go? I mean, I don't know how groups would work because either every session is online. I mean, that group needs to be together, whether they're all online or in person. But this hybrid of having the 2 people, joining, some in person, some online, doesn't seem to work really well.
Right. Yeah, I agree with that. If it's me talking to someone over the phone and doing a check-in and it's a quick 15-minute check-in, I can do that over the phone. They can come in if they want to do that. That doesn't really make a big difference, but it's a little different if it's group setting.
Yeah, and in Ontario, for the physician visits now, we cannot continue to just see people exclusively online. They have to have at least one visit in the last 2 years with us in face-to-face, or there has to be a referral from their referring physician. But still, and we are trying to accommodate people who have mobility issues and can't make it. Of course, we will do that, and I think that's really important. And calling into groups, then that's the other one. Kristen can't use video. What about the call in? Like Tracy has a question about people calling in?
That's a fantastic question. So we do have people who either don't have access to the technology to do group virtually, like with video. They don't have email, they don't have internet, whatever it may be. So we do call people into groups. WebEx does have that functionality. So we can actually, while we're in the group as the host, I can put in someone's phone number, put in the display name I want to show. So we go by first name only to protect confidentiality. And the system calls them, they pick up, and then they join group, and it's just like they're on a phone call with us, like a conference call. So they can't see anybody, no one can see them, but everyone can hear them. And then they just show up as a little gray box with their name in it. So we just flag for everybody, so-and-so is in group today, but they can't see us. So please introduce yourself before you speak so they know who's speaking. That's kind of how we manage it. But we do include those people into group because we know it's a valuable resource.
And Alex, from your perspective, if you've attended a group like that, how would you take to where somebody doesn't have their camera on, or somebody's called in like this and they're a group member? How do you interact with that?
I don't have any problem with that. It's very similar to having any other person in an online group. You just don't really see their picture, that's all.
Mm-hmm.
Yeah.
Yeah. All right. So that certainly can work out. And I guess I think what I'm hearing also is that you're managing the expectations, you're creating the respectful, you're using the technology to call the person, you're making sure that everybody knows what it is, and it can still be inclusive. So that can work. Um, and uh, uh, and so I guess people are talking about some of the difficulties that they're having. I think Lynn is talking about hybrid online in person. There's been issues with being heard when our microphone in person was not sufficient, or the individual computer couldn't adjust their settings on the platform, and it would consume group time. And I think I noticed that what you have done has been a way to prep for that,
Mm-hmm.
right? So do you want to comment on that question?
Yeah. So, I mean, that makes perfect sense to me in terms of the issues with technology. I think that's something that we all kind of constantly struggle with. So yeah, we did for a while. We were doing for anyone who's new. I think we still do it. Most people are getting more comfortable with the technology, so it's kind of dropped off. But test calls with people just to make sure their audio is working, their video is working, they know what the functionality of WebEx is. And we would do that individually so we could spend the time because it did take up a lot of time in group. But aside from that, I really like your point about, having the kind of one-offs of people joining virtually through the in-person option if they couldn't make it, because I think that that's really inclusive to be able to do that, to say, okay, you have the availability, but there's something preventing you from physically being present. So that's a really interesting point, and I think that's one that makes a lot of sense.
Okay. So, there's issues around evaluations. I can't tell if there's been an evaluation. I have not yet found any papers that have looked at evaluated this in person. I think there's been some, there's a lot of this, like what's going on, what should we do? It's been an adaptation. So, Huma, you've had experience prior to becoming a therapist with NDC with more asynchronous sort of, with the tech model and this model where you're trying to be synchronized. Everything has to happen at the same time.
Yeah.
Can you reflect a little bit more on, as we're using hybrid models of asynchronous communication and asynchronous ways of connecting with people who are, addressing the health issues?
Yeah, I think, it makes sense to have that option available, especially in the work we do, because I think so much of it is peer-based for us too, in terms of groups. We want people to be able to share their experiences and what's working and what's not working. I think the benefit of having it being kind of live and with us is we can kind of guide those conversations so that we can make sure that they're helpful for people. With the asynchronous piece, you do have to have someone who is kind of overseeing those pieces. So for example, if it's a discussion board, you have to have people assigned to monitor that discussion board and respond to people in a timely manner. And so that takes a bit of planning in order to make it work. But I think you know, it's being done in different places. I think Smokers Helpline has a chat feature, and you know, there's other supports, and even, you know, Reddit. I've heard people have found Reddit to be really helpful as a resource for connecting with other people going through similar things. So things like that exist. In terms of our ability to do it at the clinic and what that would look like, I'm not quite sure. But I know it's been done, and I know that people find it helpful. So, yeah.
Yeah. And I mean, Alex, you mentioned a little bit about, you know, online forums where you don't see. Can you talk a little bit more about what is happening in that space where people are using online other ways of getting help that are not necessarily linked into professional, you know,
Right.
systems?
So you mean you're referring to my earlier statement that I'm of a generation that's more or less native to
Yeah.
online, to the digital space. Well, the changes that I see, obviously the biggest change that I see over the past 2 years is the just therapy being aggressively marketed to people online. So
Mm.
BetterHelp.com would be just one of those resources, perhaps the best known one. I'm not affiliated with them, not advertising. It's just the one that I hear all the time in radio commercials. The other thing is, well, I think people like me just, you know, there's just a lot more information at our fingertips. So if you know how to use resources properly, you know, if you know how to identify, yeah, like everyone who does research knows how to work with, who knows at least a little bit about how to work with resources. So if you know a little bit about that, that's definitely something that people of a previous generation perhaps didn't have access to. But I think all of that together, the aggressive marketing of therapy plus availability of information, I think I think that is a big part of the reason why people of my age group are much more comfortable talking about mental health, period.
Mm-hmm.
I think that those two factors, the marketing and the availability of info, have greatly contributed to a very different dynamic between mental health care and it just popularized it really.
Yeah.
So there's
And that could be asynchronous. You don't have to see the therapist. You're just using text-based communications, asynchronous as a group. Like, is that, how comfortable is that, or how popular is that compared to, no, I have to see my therapist face to face for that 1 hour, or is it a combination thereof? How are you seeing it?
I have personally never purchased any services online of therapy, but I imagine it's very similar to what we're doing here today.
Yeah.
So whether I can speak to the advantages or disadvantages of using both, I don't know. I would have to think about that. I think in my particular case, like I like seeing people in person, like I said earlier, to establish a rapport. So that helps me, and then I can you know, do my own research online as well, which is very
Yeah.
interesting. But for other people, I imagine it doesn't really make a difference, to be honest with you. I think that they can just go into the online mode very comfortably, and if they need to switch to in person, well, might feel a bit odd, but I think
Yeah.
people are very comfortable jumping into it right away if they have the resources and, you know, a computer and a space.
Yeah. I guess what I'm hearing is that basically we're going to have to be way more adaptable and widen the options that people have to access care. So for some people, they would want online for all the reasons that you were talking about earlier. Others would want to come in person because of their personal preference or because of their situation, and vice versa. And that in the same person, the situation might determine whether they can show up in person or whether we would have to, you know, we do it virtually and be flexible with how we approach these situations.
Yeah.
Leslie had a question there, which is, I think she put out twice, is have you ever surveyed participants to get their views on how well the groups work virtually, especially when there are combo or participants on video and on the phone? So any insights, Huma, to that question?
Yeah, we haven't done any formal evaluations on that. It's kind of, you know, I think we kind of gauge it by whether people come to our group or not. We have people who've been in our group basically since we started the groups virtually, so they've kind of stuck around, and the feedback is that it's helpful and that people are getting stuff out of it, and some people feel like it's not the same, but they're still enjoying it. And some people have opted to not do the virtual groups, and that's, again, personal preference. They don't like it for whatever reason. So short answer is no, we haven't done any surveys, but we are getting like feedback from people saying that they do enjoy it.
So I think it's, so Wellness Together is a great resource. Thanks for sharing that, Kathy. So in terms of, other areas that, I guess I can talk a little bit about is when it comes to people who are quitting, it's other substances as well that's going on, when it's the other stuff. And I want to know how you what are some of the things that you've done? Typically when people show up for in-person groups, they aren't smoking during the group, they are using other drugs, or they're not just recovering. There's a way for us to do that test. How are you handling that when it's virtual? And how do you set those rules? And how do you manage it in the moment?
Right. So, I mean, I can say we haven't had too many issues with this, which is fantastic. I think people have kind of adapted to the virtual care quite well. And the way I preface it for people is, pretend like you're in a physical room with us when you're in group. So how you would behave in that physical space if you were, in the basement of our old building with us doing group, that's kind of the expectation we have when you're on camera. So we do ask people not to smoke while they're on camera. Obviously, that's triggering for people. We ask them not to drink on camera. We obviously ask them not to attend intoxicated. And that hasn't been an issue for us. We haven't had really any incidences where I felt like, oh, I don't know, like this person's not, not grasping the concept of that. So luckily, we haven't had to deal with any of that. And I think people are really fantastic with, if they are in that state where they've had a few drinks before group, they don't come to group that day. And they may connect with us after to let us know that that's what was going on for them. But yeah, it seems like it would be something that would be more of a concern. There's been a couple times, I think, where people have kind of lit up a cigarette, not thinking about it on camera. But in that case, we turn off their camera. We have the ability to do that in the session, and we address it. And that's kind of how we manage it. And again, like that wouldn't happen in a group room for sure, because they're in the physical space with us. So that is just a tiny little difference, but it hasn't made a huge difference for us.
Yeah, and then there are some questions there that, there's misinformation all over the place. And here's where I guess I'll let you start off with how you handle it, then I'll go to Alex, and then I'll reflect on how I've been approaching it. So maybe Tracy has this question about misinformation and people are bringing online into the discussion. And how do you figure out I heard you should take this or that?
Yeah. Well, I'll say that hasn't changed since we moved to online. It hasn't increased at all. I would say maybe just the nature of the situation we're in globally in a pandemic. There is a lot more conflicting information out there. And as Alex kind of mentioned, it's marketed more to people like on social media nowadays. So that may be one thing, but that was something we dealt with before too, in terms of a lot of misinformation on the best method to quit smoking, or how to use the patches, or whatever it was, menthol cigarettes compared to regular cigarettes. So we've been kind of dealing with that as best we can with just evidence base that we have, and just sharing, this is what we know. This is the information we have through research, and at the end of the day, people are adults and they can make their own decision on whether or not they want to follow that information or not. So that's how we mention it. We address, if it's anything very obvious that's going to cause harm to people, we do address that. But for the most part, all we can do is provide people with the best information we have, and have a discussion about that information openly.
Thanks. Yeah. And how do you, in online groups where people are putting in links and all sorts of information, Alex, what kind of recommendations do you have? Because somebody could put something in that they've seen, in person that doesn't happen. Online, it's easy to easily plop in a link or something. How as a consumer of services, how would you handle that? What is the role of the facilitator? What do you think your own role is?
When it comes to handling outside information, like a link?
That comes into the group. Somebody brings in a resource that may or may not have been vetted, or how do you handle that?
Right. Well, you can't, unfortunately. I mean, people are free to share resources, and that's usually I find that people share things that have really worked for them. So that's one thing. But the other thing, you just have to be vigilant on a personal level, just like with any other bit of information. You're well advised to doubt it on a
Yeah.
fundamental level.
Yeah.
I think that's the basic principle behind consuming any information. You just have to have you have to have a you have to be able to doubt it, not to discredit it, but in order to make sure that in order to validate it.
Yeah. Yeah.
And I can
mean,
add
go ahead. Yeah.
logistically, sorry, Peter, I was just gonna say logistically, so we do disable the function of participants to chat with each other. So they can really only chat with the moderators of the group.
Yeah.
So any links that are sent directly to whoever is facilitating the group. So that's one of the therapists. And there's usually two therapists in the group facilitating. So what we do is, whoever is taking notes that day will usually go through the link and check to make sure that it's something that would be helpful to share with everybody. And that's kind of how we gauge some of that information. We don't allow participants to privately talk to each other because we knew that might be a source of an issue. So that's kind of how we manage that live in group.
Yeah. And one of the things that I agree with you, this, we're in the day of where information is accessible and it's legit or not legit. So in general, whether I'm seeing somebody in person or online, I accept that the people have information. So I often start my sessions with people as, so what have you learned, or what is it that you know about what it takes to quit smoking? Like as an open-ended question, and what are your, what have you heard about the medication? What have you heard about the counseling? What do you think it takes? And so it's really an important way to know because people have done homework. I think, and make no assumptions. People who you might think may not be literate actually can have quite a lot of access and quite a lot of information. So I've been using a strengths-based approach, essentially just starting off with that. And so then you get to know where people are at, and then with permission, you can clarify whether they are, if there's a strong held belief, there's nothing you're going to say that's going to change their minds. But if they're open to it, with permission, you can provide your best, professional advice, and then it's up to them to take it. So that's some of the things that we've been, how we've handled this issue around, like we have to, as healthcare providers, have to understand that the internet exists, people can have access. It's 80% of Canadians have, more than 80%, actually, it's getting closer to 90%, have access to the internet, high-speed internet. So it's there. People and people talk. So that's part of it. And again, as we're adopting technology, we have to manage the personal communication. People, just setting the parameters and the rules around email communication of personal health information. I mean, our health systems need to have better secure communication platforms with healthcare providers. But again, one of the things when you're doing this kind of work is having protocols for managing when crises happen, right? So how can you talk a little bit about, I know we have a few minutes left, but I really want to talk about when things are going bad. So if you notice somebody's getting into an unsafe situation, somebody is suicidal or things like that, how are some of the ways in which you've handled that?
Sure. So, I mean, in group, that's what we have the check-in at the beginning of the group for, is we usually ask people to rate their mood for us and have a bit of a discussion if they rate it lower, just to make sure that they're safe. We have, one of us is, like I said, we double facilitate the groups, and that's for a reason. So if we have in group been concerned about someone from the things that they're saying, or, it's clear that their affect is telling us that they're quite low, one of us will call them on the phone. We'll, turn off our cameras, we'll leave the group, and we'll call them to make sure they're okay. And then we kind of, in terms of crisis, as you mentioned, Peter, the way we manage that is, again, we're at a distance from them. So it's not like we can walk them down to the emergency department if we need to. But if that was the case, I would support them with, helping them make the call to 911 if they needed an ambulance, connecting with a support if they had a loved one at home with them who could support them getting to the emergency department if that's what they needed to do. So there's other ways that we can support them. It's not a physical, like, let me walk you down the street to the emergency department as we once used to. So that's how we manage that. And then, of course, follow-ups, right? So following up with them the next day to make sure that they're doing all right, that they were able to get the support they need. That's how we manage those situations in a distance situation.
Yeah, and we have the STOP program, which is provides nicotine replacement to people either through their healthcare practitioner's office or directly. And as part of that, is the standard is screening for mood states and depression, and we do get occasional people who do describe suicidal ideation, because as we know that can happen. But we have a protocol that goes from trained RAs who can listen to that, then know when to have the resources for people. So in that virtual model, even though we are in Toronto, they can be anywhere in Ontario. We are able to then connect them with resources and escalate that to a clinician or and that who can take over from them. So there are ways in which if you're doing hybrid work and you're doing remote work, that you can still build in safety.
And that's how crisis lines have managed for
Exactly.
years, right? That's
Yeah.
the purpose of crisis line is, they don't know where you are, but
Yeah.
they try to get that information. And if they're worried about you, they will send help to you. So
there you go. Exactly. So that's it, right? So if we take that kind of approach, that here's a technology, technology is nothing, no single technology is perfect, but it's an enabler for connecting and we need to use it. But as we are bringing people into this idea of also coming in person, there are some values that are required for that. Clearly, during the pandemic, we had the budget to be mailing out nicotine replacement to even if they live down the street.
mm-hmm.
But as the health system is recovering, we're gonna, people will have to come as well to pick up medication. So there are these pros and cons as we have this hybrid model, and some people. So we're having to set some rules. Like, okay, so if you have transportation problems or mobility problems or things like that, yes, fair enough. Or you got other significant health issues that preclude travel, then yes, we'll do remote. But otherwise, there's an expectation to come. And so I want to hear from you, Alex. Is how does that sound when the system is sort of reattaching to this hybrid model? And as a provider, we said that to you. Well, for these things you need to show up, and these other things we would do that. How does that sit with you? How do you think that'll sit with other users of the system?
Probably not too well with people who got used to it, who are very remote.
Mm-hmm.
I'm not, so
Yeah.
it doesn't really matter for me.
Right.
But I would imagine that for people who, and people with mobility issues especially, I don't know how they would deal with that. I imagine that it would be of some benefit to keep some of the budget allotted to the delivery.
Yeah, absolutely. You're absolutely right. We have to. I don't think we can. That's why I say you can't ever go back. You have to go forward with this new model and think about what is your local context, the populations you're serving, co-design as much as possible as you can to meet the needs and adapt to the needs as they are happening. Because I think that's where we are at. And so, all right. We have a few more minutes. I want to just go around and ask you, Alex, other thoughts that you wanted to share with the attendees today? Anything we didn't cover? Anything you'd like to make sure people got?
No, I think if anyone has a specific question for me, that's totally fine. But other than that, I think I've expressed everything that I needed to say.
Right. Yeah, and Huma, thank you for answering that question. But anything else that we didn't cover, or anything else that you'd like to make sure?
Attendance. Yeah. Okay. So the attendance. It's hard to say really if the attendance is better for virtual versus in person. Like I said, I think in terms of the number of people who show up, it's relatively similar. But what I will say is the number of people we have in group is higher now than it's ever been. Because like I mentioned, we're running more groups than we ever did. We used to only have like 1 or 2 ongoing groups. Now we have 6 different ongoing group cohorts. And we had to do that because the demand was so high for the groups that we literally had to make them bi-weekly instead of weekly and split them into 2 cohorts. So we run them every week. People attend every other week. So I think if we continue to do it the old way, we would definitely have like 8 or 9 people every week in group. And people wouldn't have enough time to share what's really going on with them. So that's why we've split it. So 2 parts to that question, yes and no.
Yeah, and I can tell you as a physician, in terms of virtual, I had way more show than in person.
Yes.
And in fact, I would recommend not to do 1 visit virtual, 1 visit, because what happens is the in-person visits typically tend to run long. And so then the person online is waiting and they don't know when you're going to call, so then it just throws everything off. So as we are evolving this, we are thinking, if you're doing virtual, do that whole clinic virtual. Don't try to mix virtual match, or do, in person. And then if there's a no-show, you do a virtual visit for that and tell that person to be on standby. So, we are working these things out, and that those are the kinds of things that how we are approaching it. So hopefully this has been helpful to everybody. I know we have about 3 minutes left, so I just want to make sure if there are any other questions that come in the chat, please feel free. And Huma, I want to point out to your response to Claire about how you keep privacy and use the BCC function as a way so that it doesn't violate people's privacy. But any last minute? Otherwise, I want to thank everybody for their participation. And of course, we are always here. You can reach out to us. As always, thank you to Natalie for herding us like cats and herding me especially. So thank you very much. And great discussion. So thanks. And again, thank you, Alex, for your time. And thank you, Huma, for sharing your expertise as well.
Thank you.
Thank you.
Yeah, thank you so much, Dr. Selby, Huma, and Alex, for such a great discussion. I can see that everyone really enjoyed it through the chat, which is awesome. Just a couple reminders before we head off. If you are interested in receiving the letter of completion, the evaluation and post-learning assessment will be emailed to you by the end of the day, and we'll also send along this recording in that email as well. And a heads up about our next Teach Educational rounds will be on January 25th in the new year. So stay tuned for that registration shortly. But I think that's everything. Thank you so much, everyone, for your participation today. And I hope everyone has a great rest of their day.
Thank you.
Bye, everyone.
Bye. Thank you.